Good afternoon. My name is Gary Morrison and I'm part of the management committee of the Shine a Light Cancer Support Group based in Sydney in Australia. I'd like to give a warm welcome to everybody. Good afternoon or good morning, no matter where you are. We have people from throughout Australia as well as New Zealand and parts of Asia. I'd also like to extend a very, very warm welcome to our two speakers today, Professor Kurt McCammon and also Dr. Amanda Chung. My co-chair, Kalli Spencer, will be doing a more formal introduction when I hand over to him. Before we do start, I'd like to do a welcome to country. In recognising Aboriginal and Torres Strait Islander people's spiritual and cultural connection to country and in continuing commitment to reconciliation, I would like to commence the meeting by acknowledging the First Nations people and the traditional owners and custodians of the country where we are located. We respectfully acknowledge our elders, past and present, and remember that they have passed on their wisdom to us in various ways. Let us hold this in trust as we work and serve our communities. Again, welcome to everyone. The topic for our webinar today, which is the fourth in our series this year, is prostate cancer, urination troubles after surgery and radiation therapy updates. Going back in 2021, we did hold a conference on a similar theme and had just an absolutely overwhelming response to that webinar. And we thought that it would be great to do an update session this year within the webinar series. It's an interactive session. We want to get through in this 2 hours as many questions as you may wish to ask. My co-chair, Kalli Spencer, will do a superb job, I know, in running this session, and I'll contribute where I can throughout. Again, a warm welcome to Kurt and also to Amanda, and a warm welcome to all of you participating in today's webinar. Kalli, over to you.
Thanks, Gary. And great to see you all again. And yes, welcome to our speakers. You've all been given their biographies in the introductory email, so I'm not going to read through them, but just know that we're in good hands here. You know, both speakers are internationally acclaimed and certainly are called on in various parts of the world to deliver presentations, to write journal articles, to do research, and to create guidelines. So we're in very good hands, and we're so fortunate to have you both address us today. So I please urge and beg of our listeners to ask as many questions as you can and want to ask about troubles related to urination after your prostate cancer treatment. After prostate cancer treatment, you know, you can leak, or you cannot leak. It can be a problem related to your bladder, or it could be a problem related to your urethra, or it could be something in between. It can be a simple problem and it may just go away, you know, just as quickly as it came, or it can be very complex. It can be a short journey, or it can be a very complex journey that can go on for a very long time. And it can have a significant impact on one's life in terms of day-to-day function, in terms of socializing, and in terms of mental health. So it is a big problem, but the good news is that it can be treated. You know, no one has to leak, and there are options available. And I think that's what we want to get out of today's session. Last year, we did talk about this, but this year we want to just expand a little bit more and look at the different types of urinary incontinence. So most of us have heard of stress urinary incontinence, but there's also something called an overactive bladder, which can result in urge incontinence, where you need to run to the toilet all the time. And there's many different reasons for that, as we'll hear. And then the other thing that's not really spoken about a lot is that you can get a blockage, or what's called a stricture, or what's called bladder neck stenosis, or bladder neck contracture, or vesico-urethral stricture. So there's many different names almost for the same thing. But our speakers will go into this in a bit more detail. So the plan is to start with the evaluation, then go into stress urinary incontinence, overactive bladder, and end off with bladder neck stenosis. And we'll alternate speakers, starting with Dr. Amanda Chung, who has trained here in Australia and also with Professor Kurt McCammon over in Virginia, USA. So let's begin. Amanda, over to you.
Thank you so much. Thanks, Dr. Morrison. Thanks, Dr. Spencer. Thank you so much for having me here today. A real pleasure to join with you. Will I have the slides to share up on the screen?
Yes, you will.
Thank you so much. So thank you for that warm introduction. I will start off by talking about the assessment and evaluation of urinary incontinence after prostate cancer treatment. So clicking ahead to the next slide. So urinary incontinence affects about 5%, depending on which studies you read, in some populations about 5%, 10%, or even up to 40% of people after prostate cancer treatment. It can affect people of all age groups, doesn't matter what age prostate cancer is treated at, although it tends to increase at the older age groups. Most urinary incontinence after prostate cancer treatment is stress urinary incontinence, and we don't mean psychological stress when we say that. What we mean is that the urinary sphincter doesn't hold as firmly as it used to, and so it lets the urine out. About 40% of people, though, can have overactive bladder develop. So not all urinary incontinence after prostate cancer treatment is stress urinary incontinence, as Kalli alluded to. And also there's a specific kind of incontinence that can happen during orgasm, or climacturia, we call that. Urinary incontinence is a real bother. It can be. It can have, the biological costs, of course, but also can cause a lot of psychological stress and depression and anxiety, as well as financial costs. Pads aren't cheap. Other continence coping mechanisms, whether it be catheters or urodomes or whatever it is, they're not cheap either. When urinary incontinence can occur, it can occur after prostate cancer treatment. We use that broadly because it can occur after surgery. It can also occur after radiotherapy and other types of treatment as well. Am I able to make the slides go forward by myself? Sorry, yeah. So in terms of urinary incontinence, it's the involuntary leakage of urine. Like we alluded to, there's two main categories. So the stress urinary incontinence. So often people will describe that as, leakage when there's lifting something heavy or bending down to put on their shoes, sneezing, coughing, and so forth. Or there's urgency urinary incontinence, which is leakage where there might be a strong desire to feel like wanting to urinate, but before getting to the toilet in time, there might be some urine that comes out. And sometimes people would describe it more as a key in lock syndrome. So when a key is put in the front door, then they feel their bladder really squeezing and can't quite make it to the toilet in time. Some people are unlucky enough to have both, some stress incontinence as well as urgency incontinence. It's quite important to sort of delineate, whether it's one or the other or both, because that will help to ensure a successful treatment. And like we said, yes, it can cause a lot of inconvenience, a lot of reduction in quality of life, and can stop people from enjoying the things that they want to enjoy. From simple things like, I have people tell me, they really, miss being able to wear cream colored or light colored pants. They have to change, their wardrobe because of, fear of leakage, or it can be, much more than that. And they might not go on the road trips they want to, or socialize with their friends like they would want to, because they always have to, they're embarrassed by having to go to the toilet or run to the toilet frequently and so forth. Next slide, please. So just to review the anatomy, so the bladder is a ball of muscle, and that muscle is called the detrusor muscle. Underneath the bladder is the bladder neck, and then the prostate gland sits beneath that, and in a radical prostatectomy, it's removed. And the urethra, which is the tube that travels from the bladder neck through the prostate and through the channel, it is then re-anastomosed or reattached with a suture from the urethra, where that underneath the prostate where it's been cut, back up to the bladder neck. So you can imagine how sometimes if the prostate is removed, that it can cause some disruption to the urinary sphincter, which is quite integrated with the prostate, and therefore cause some sphincter deficiency there.
Man, I'm just going to interrupt
Yeah.
and just remind everyone to please post your questions in the Q&A or the chats just below at the bottom of your screen, because after each of the 20-minute talks, you're going to have a chance to ask the speaker those questions. So please keep the questions coming. Sorry to interrupt, Amanda.
Oh, not at all. So we talked about, bladder factors or sphincter factors. So with the incontinence is overactive bladder, that's a bladder factor. So it's really the bladder either spasming and pushing the urine out, or you can think of it as a stiff or a tense bladder. We often call that technically a non-compliant bladder. It doesn't want to relax and stretch and accommodate urine. And so that can cause urgent incontinence and the urine to be pushed out accidentally. The other aspect is the sphincter factors. So where there's a weak sphincter, weak pelvic floor, and that's where, you know, coughing or straining or lifting something heavy can result in stress incontinence. Thanks. So in terms of the causes of stress incontinence, different studies have shown different things. After surgery, increased age can increase the risk of having stress urinary incontinence. The degree of difficulty of the operation can also play a factor, as well as the involvement or the stage of the cancer in terms of the sphincter, and it can help determine whether or not a nerve sparing operation can be done or whether those need to be sacrificed in order to get a good oncological outcome. In terms of radiotherapy, age also can make a difference, the dose of radiotherapy, as well as what form of radiotherapy is given. This is a table showing some studies which showed the continence rates at 12 months after different kinds of prostate operations where the prostate is removed for prostate cancer. So you can see here some of these studies have a lot of patients within them, so 600 or so patients in some of them, and you can see that the age usually is generally around sort of 60s. In terms of how we define continence, can really change the stats quite a lot. So if we're really talking about complete dryness, there actually, you know, there's the majority of patients generally in the studies will have complete dryness. But if we're loosening the definition a little bit to say that they can have drops, you can see that there the success rate, the continence rate therefore is reported a lot higher, you know, in the 90s generally. Or if we're allowing, you know, 0 or 1 pad, to say that that's, you know, not too severe, although maybe very bothersome and distressing for people, then the success, you know, the continence rates are pretty high as well, so 80s and 90s and so forth. In terms of how to diagnose urinary incontinence, well, that's sort of quite easy from the point of view that we hear what you say. If you say you're having involuntary leakage of urine, you've got incontinence. But in terms of other information that is really important to, you know, describe to your doctors, and your doctors should be asking you as well, you know, things about you as a person, you know, your general health, your dexterity, you know, how you're going with your cancer control, and your urinary control and the severity and how much it bothers you, because all these things come into consideration when trying to decide how much should we investigate this issue and what sort of treatment options are available. Are they quite simple ones, or is it worthwhile pursuing more involved treatment and investigations? In terms of physical examination, really a flow test and a post-word residual bladder scan can be done just to make sure that it's not overflow incontinence. The degree of bother really matters, and I think that everyone who can should do pelvic floor exercises to help their sphincter be well conditioned. Not everybody wants surgical treatment, so please don't feel pressured that you must, and I hope you never feel pressured by your doctor that that's the case, but it's definitely available if you do want to have it. One consideration is how bothered are they or you with the level of incontinence? So in terms of pad usage, but also personal perception. You know, there are some people that might be use multiple pads a day, but it doesn't really trouble them. Whereas there are some people that, you know, might be half or 1 pad a day and it really is distressing for them. So all these things really matter. Of course, only people who are significantly bothered require surgery. In terms of pelvic floor muscle exercises, it would be good to do at least 3 sets of 10 contractions daily and link in with a professional pelvic floor physio to make sure that if you're going to make the effort to do this, that you're doing it as effectively as possible. and contracting the correct muscles. And this can be something that started even before prostate cancer treatment. In terms of management, initially, pads, so different sizes, and you can speak to your local urology or community nurse or pharmacy regarding that. And yes, of course, they're unfortunately quite expensive. In Australia, there is some access to funding for continence pads. And there's paperwork that can be done to help access that. So if someone has incontinence, how long should they wait before seeking treatment? Well, if they've failed pelvic floor exercises, or it's been beyond about 6 to 12 months, then it would be reasonable to seek further treatment. The reason why it's good to wait a little bit initially is because the sphincter can recover spontaneously up to 12 months, but beyond that, it's unlikely to recover very much more. However, if the incontinence is really severe and it's only been 6 months and someone is leaking, say, 5 pads a day, it's really unlikely that even if they were to wait a full year, that they would get down to a level of incontinence where they wouldn't want treatment anymore. And so it'd be reasonable to offer treatment, sooner rather than having someone, persist or suffer with it for longer before accessing treatment. In terms of how we can further delineate what kind of incontinence, we talked about the 2 different kinds, stress incontinence or overactive bladder incontinence. There is a test called a urodynamic study. It's essentially like an ECG, but instead of for the heart, it's for the bladder. There's a little sensor line placed in through the urethra into the bladder with a little filling catheter. There's a little sensor line placed up into the bottom. And a lot of people say, oh, you're testing my bladder. Why have you got to put anything there? And it's really because that's how we monitor abdominal pressure. It's all connected to a drip stand and the bladder is filled slowly. And we can see on a computer monitor these tracings or lines, similar to like an ECG, so to speak, but for the bladder. And we can see what the bladder pressures are like, the capacity, is it doing any sort of overactive bladder spasms, and so forth. And then often people will be asked to cough or strain, and we can see what the leak point pressures are. And then also importantly, how the bladder contracts when it does empty. Because if your doctor's thinking about doing a surgery, for example, to help bulk up or close up the urethra or make it hold more firmly, then we of course also need to know that the bladder, the ball of muscle, squeezes like a pump well enough to push the urine out, because we wouldn't want to tip someone the other way to be hypercontinent where they can't empty and they have retention instead. So these pictures here are sort of pictures of what the urodynamic machines look like. These are the computer monitors with the machines, and the one that I've got in my private practice rooms is the one in the middle, where basically it can be dismantled and put in this Samsonite suitcase and then tossed in the car to be driven to my other clinic locations. So it's like a mobile urodynamic service. This is an example of the graph that the urodynamic study shows, and I will talk a little bit more about this in the third talk of today. But the blue line is basically what the bladder pressure is like. The red line is the abdominal pressure, and the green line is the subtraction of these. So that really tells us what the bladder muscle is doing. You can see as the bladder is filling, the bladder muscle is tightening. Here, where it goes up and down, is where we've asked somebody to cough, and we can see what they're, at what sort of abdominal pressures they start to leak. And then here you can see the bladder naturally squeezing a bit in order to empty out. This is another test that can sometimes be that might sometimes be done in order to have a look at why someone has urinary incontinence or some other features, or to rule out some other causes of overactive bladder incontinence, to make sure that it's just overactive bladder syndrome as opposed to something else. So this is a cystoscopy. It's basically a camera test to look inside the urethra and into the bladder. So it can be done with this flexible scope, so quite a skinny scope made for this scenario in order to have a look inside.
Next slide, Nicholas. There's a question in the meantime while we're waiting for your slide to change, Amanda. Are you there?
Yes, I am.
The question was related to someone who's just had a AUS sphincter put in, and they've got bruising and swelling from the operation, and they haven't been able to pull the controller down into the scrotum daily like the urologist said they should. Is that going to cause a problem later when the AUS is activated if the controller is sitting high in the scrotum?
That's a very good question. It's not every urologist asks the patient post-op to pull the scrotal device down into the scrotum. And the true answer is time will tell. So it's not always routine for everyone. It's sort of a bit of preference. So there are a lot of people that don't routinely pull it down and they do just fine and it heals in a good position. So I wouldn't be too worried. However, if there really is a big sort of hematoma there, sometimes it can push the scrotal device up too high, and it can sometimes make it difficult to activate in the future. But generally speaking, it would be a matter of resting up, not worrying about it too much, and seeing how all the swelling settles down. If worst case scenario, the device heals in a way that's too awkward for proper use, then a urologist can do a secondary procedure in order to reposition that device down into the scrotum. But usually it heals in an okay place.
Kurt, did you want to add anything while we're waiting for the slides to come back on?
No, I would completely agree with Amanda. I think the very few times if we had to take a patient back to the operating room to try to repair something like that. So most of the time, everything works completely fine.
Here's another question for you, Amanda. Thank you for your response. Before doing the urodynamic assessment with the machine, do you look at lifestyle like being overweight, eating spicy food, alcohol consumption, citrus fruit consumption, etc.?
Yes, absolutely. And the way I've sort of structured my talk is I hadn't gone into that part yet, but I will go into that a bit more when it comes to the overactive bladder side of things. I've just kind of categorized it that way, but absolutely. In general, we'll go from, lifestyle modifications, dietary modifications, and those, more conservative sort of strategies, and then just escalate, to more involved strategies, whether it be medication or, surgeries. And also surgeries, there are, minor ones and there are more major ones. And we would, as a principle, go down that sort of algorithm. So yes, we would try those sorts of easier things first.
Thank you, Amanda. Your slides have returned. You can continue.
Oh, thank you so much. So this is another picture of a cystoscopy. Basically, this one is a rigid one, which basically has a working channel so that if something is found inside, like a bladder stone is the reason why the bladder is spasming and, squeezing this urine out accidentally, then it can also be treated or broken up at the same time with this special type of scope. These are some cystoscopic views of what we might find inside the bladder. So the first one up here, that's actually a bladder stone. So that can be a reason of bladder irritation, people needing to go to the toilet more frequently, urgently, waking up in the night, or even their bladder spasming and squeezing urine out accidentally. And then here on the right-hand side, we can also see a bladder tumor. So this frond sort of almost coral looking sort of growth is actually a bladder tumor, and that can also cause irritation. There is also sometimes in the future a little bit of an increased risk of secondary malignancies that can occur after radiotherapy has been in the area. And then here at the bottom left, these little red spots are actually what we call cystitis cystica. So there are some people who may get recurrent urinary tract infections, and it can show up as these little sort of pimple looking spots within the bladder. So sort of to round off, treatment choices really will depend on patient preferences and patient factors, but also disease or condition factors, the nature of the urinary incontinence, whether it be overactive bladder, stress incontinence or something else, the degree of the urinary incontinence, and then sometimes other specific considerations too, like how sort of suitable someone is for certain types of anesthesia and whether that treatment option can be done with that. We talked about the two main categories, the stress incontinence and the overactive bladder. And Professor McCammon will talk a little bit more about the stress incontinence treatment options, and then I will follow on with some overactive bladder advanced treatment options too. So take-home messages for this first part of the talk is that, urinary incontinence after prostate cancer treatment is often due to sphincter weakness rather than the bladder, overactive bladder. It's important to be diligent in pelvic floor exercises. And if someone's significantly bothered by their degree of incontinence and it's not getting better, then surgery can be offered. And there are different options available, which we'll go into in the next segments. Thank you so much.
That's great. Thank you, Amanda. Just one or two questions for you. Is there a difference between having brachytherapy and external beam radiation therapy in terms of the incontinence or the degree of incontinence after those treatments?
With external beam radiotherapy, it can be a bit more common to get overactive bladder incontinence, or overactive bladder symptoms. It's a condition that in that scenario, we specifically call radiation cystitis. Whereas that's a bit less common when it's brachytherapy, because brachytherapy is more concentrated within the prostate itself and there's a bit less scatter to the bladder. Having said that, brachytherapy can be more common in brachytherapy to have some things that I think Professor McCammon might talk about a bit later, where there's stenosis of the urethra within the prostate compared to the external beam radiotherapy, although both conditions can occur with both modalities.
That's great. And what about focal therapy? I mean, I know it's a controversial type of treatment for bladder cancer, but the supposed advantage is that it spares continence, that you don't become incontinent. Is that true?
Yeah, absolutely. I mean, the principle behind focal therapy is to reduce the field of treatment and therefore side effects that come with that, to make it really, as narrow, so as minimal as reasonably achievable, if that makes sense, in order to, create still good oncological outcomes. So from that point of view, yes, my understanding is that focal therapy is still considered experimental in Australia, and there are very tight criteria as to who is suitable for focal therapy in terms of the grade of the cancer, the volume of the cancer, and so forth. So it's not, if the main or the first priority is to have good oncological control, not everyone is necessarily suitable for that, even though, yes, sure, focal therapy may mean that there's less side effects.
Thanks, Amanda. So I think it's time now to move on to Professor McCammon, who's going to talk to us about stress urinary incontinence. Over to you.
Good morning, good afternoon. It's morning where I'm at, so I do apologize, but so I will say good morning, everyone. Thanks for having or allowing me to be here. I may go over some of the things that Amanda went over and just say probably things a little bit differently, obviously not with a Australian accent for sure, but we'll try to just go through some things I always talk to my patients about. As Amanda mentioned, the incidence of this is actually quite high, and it's one of those things that is really almost, I wouldn't say define my practice, but it's really one of those things that I've really enjoyed taking care of. I think this is one diagnosis that we can truly make a difference in somebody's life and truly help them. So although we're not the ones suffering from the problem, we do understand the issues that patients have, and it's really great when patients get better. Amanda's kind of gone over this. I was having a conversation with a urologist last night, and it was a younger urologist in training, and they were saying they were so surprised how patients don't understand what happens when their bladders don't work. And I left this slide in because I think it's important. We don't think about our bladders ever. I mean, as growing up until I became a urologist or got into medical school, bladder never came up in my mind. I got up and went to the bathroom when I had to, and didn't have trouble with leakage or going frequently. And so it's truly one of those organs that you don't even really think about until, oh my gosh, I'm having problems. Most of stress urinary incontinence in men comes from a urologist. I mean, we're usually the culprit in causing these issues. And as you heard Amanda mention, 40 to 50% of men will have incontinence after surgery, and up to about 10% of men will end up having significant incontinence that may cause them to want to have some type of treatment. There are other conditions, neurologic disorders, sometimes treatment for an enlarged prostate for voiding difficulty, radiation, and obviously trauma can increase our risks. I think one of the most important things that I've learned, and I think it's important to have a conversation with the patient, is the quality of life issues that are associated with incontinence. And I've really found some patients who have their whole lives have changed because of their incontinence. And it's been really cool at times when we've been able to treat them and help them, how much better their quality of life's been. One of my favorite patients years ago came in to see me. He had his prostate cancer treatment years ago. He was significantly incontinent. He was poorly shaved, poorly dressed, overweight, on antidepressants, and we were just chatting, and he wore about 6 pads a day, and it truly was affecting him. We were able to do a procedure to help him, and it's incredible how he comes in a year later. He's lost weight. He has a sport coat on. His whole life has changed. He's off his antidepressants. So one of the things I would say is, if this is an issue for you, you should talk to your health provider, because there are things that we can do. There's a study that was done looking at patients and the effects on quality of life of incontinence. And as you can just see here, 26% limit what they do. So obviously then, unfortunately, patients will gain weight if you're not exercising, which then increases your risk of incontinence. We did an online study years ago, and we found out that almost 50% of men would do anything to treat their incontinence. Most of the men, 40%, would affect their relationships. And it's something that we don't always think about, because our partners are also having to deal with this when we're leaking. So it's not just you that are suffering. It's actually your partner that's actually going through this with you. So please don't get upset with your partner when they're trying to help you. You're not doing this alone. And the amount of money that's spent on incontinence is incredible to me. Not on the treatment mostly. It's about buying pads, which is just befuddling. All right, so I'm not supposed to talk about that. I was asked to talk about stress incontinence. So in the treatments, I'll skip through that. Actually, I'm going to go back, because this is the one thing that's probably important. So we have 2 sphincters, and we have an internal sphincter that we can't control. That's damaged during a prostatectomy, removing the prostate. And then our external sphincter is the one that we can tighten up, which is one our physiotherapist will help us with. But sometimes that can be damaged, or sometimes patients will have not as strong as an external urinary sphincter as we would hope. So as Amanda mentioned, there are some treatment options. You can decrease your fluid intake, but that's probably not the best thing to do for your overall health. It always drives me crazy when patients come in with that. We strongly believe in pelvic floor therapy. I don't do prostatectomies, but our group sends patients for physiotherapy prior to surgery. There's not good data showing that actually works, but I truly believe that learning the exercises before you have your prostatectomy is actually probably easier. Going to see them 3 weeks, 6 weeks after, you're recovering from surgery, you still could be uncomfortable or sore. And so I think just learning those exercises beforehand is probably better. Now, it's difficult to find insurance that pays for that, so sometimes that can be an issue, and it's probably better to make sure you understand that. And then there's coping mechanisms. So a lot of the things that I do and Amanda does are quality of life issues. And the conversations I have with patients are, we can try to manage this, or we can try to cure it. And whatever the patient decides is the best thing for them. It's not my choice if they have a surgery or they would rather wear a pad or a clamp. That's their choice. And I hopefully can help them choose what to do. With regards to coping, there are pads. And I don't like the word diaper. I could call them pull-ups. I think that sounds a little bit better. Leaving an indwelling catheter is truly not one of my favorite things, because there are obviously risks associated with that. There are penile clamps, and you really need to be careful with penile clamps, because they can lead to erosions and skin issues. Some patients will create some of the most creative things by creating something on the outside of their penis, collect into a bag. And that can work at times. The problem with that a lot of the times is it'll fall off at the exact wrong time and nowhere when you would want it to happen. And so it's really, if you can make it work for yourself, that's great. And if that's what you want, again, this is a quality of life issue, not a quantity of life issue. So it's the patient's choice. But again, sometimes you can be in an area where you don't want that to happen. And again, these can be very expensive. As you see here, pads, it can cost up to $7,000. If you walk down in Australia, I don't know what they would be called. We have Walmarts here and Targets. And if you walk down the aisle, Kimberly-Clark has made billions of dollars selling these types of devices or protection. So it obviously can be quite expensive. But there are long-term solutions. There are things that we can do that actually can improve patients and get you back to where as close to normal as you can be. And you probably can never be cured completely. And I think that's an important conversation to have, but we can get patients significantly and better. So there are male slings. This is a device that if you talk to patients about, this is what they're going to choose compared to some of the other procedures that we can do. As you can see, there was a study done by Vic Nitti, who used to be in New York City, but when he would explain options, they would choose a sling just because it's a little bit less invasive. Everything's concealed, and the patient doesn't have to do anything to void. They void normally. The sling, if it works, will compress the urethra and allow them not to leak, or hopefully not to leak. This is an artist's rendition of it. It's done through an incision underneath the scrotum and 2 small incisions in the patient's groin. And we pass this piece of mesh and kind of lift it and compress the urethra. People always worry about mesh in the United States, and I know in Australia there are a lot of issues with mesh, and that was all with females. This was not with males. In saying that, I still think mesh is good in females, and I'm giving a talk in about 2 hours on that to another group. So I think mesh slings do really work for both men and females. But the gold standard for treatment for urinary incontinence is an artificial urinary sphincter. This device is almost as old as I am. It's been around for over 40 years. It's had some improvements, but in all honesty, it works really well. And the companies haven't had to change it too much. Again, it's undetectable. And it's reliable. So this is what the device would look like. In my hands, it's done through 2 small incisions. Well, every surgeon always says their incision's small, so I don't know if that's a true statement, but it's done through 2 incisions. One is underneath the scrotum, and then one is a small incision, kind of where you would have a hernia operation. Through the incision underneath the scrotum, we put the cuff that you can see it's wrapped around the urethra. There's a control pump in the scrotum, and then a little reservoir up in the abdomen. And so how it works, I think the next slide is probably better. So once the procedure is done, for the first 6 to 8 weeks, depending on your urologist, you'll continue to leak. This will not work initially. And then what happens is once he or she activates it in the office, this will then work hopefully all the time. How the sphincter is activated, it's actually relatively simple. People are always usually very nervous about that process. That's done through just squeezing the cuff a little bit harder than you would do normally when you're doing it yourself. So this is how once it's activated, this is what the sphincter looks like. So as you can see, the cuff is now closed. It's squeezing the urethra, and you can see the artist's rendition where the urine is being stored in the bladder. When the patient feels full, you'll get the normal sensation. That's one of the questions we always get. Well, will I be able to know when I need to use it? How am I going to know? You'll know. It's just going to be like when your bladder worked before. So you'll go into the restroom. You'll squeeze the pump 2 or 3 times. And what that does is you can see the arrows in the yellow. It transfers the saline from the cuff into the pressurized balloon reservoir. That allows the cuff to open up. And as you can see, the patient is then urinating. After about 30 to 60 seconds, this pressurized balloon reservoir then pushes the fluid back through the pump into the cuff, and then the patient now is continent again. Yeah, as I said, it is an outpatient or 23-hour stay. And again, 2 small incisions, just like any surgeon says. I've never made a big incision in my entire life. And we usually activate it in about 4 to 6 weeks. It's important, though, to talk about success rates of this, because for a patient to understand what to expect. When I was young, like Amanda, I would tell people, oh, if you look at success rates, it's 90% of patients are cured. And that's what the literature would say. But that's actually not true. And if you really read the literature, it's 90 to 94% of patients are 0 to 1 pad. And so if you don't understand that, you're going to come back into your urologist's office and say, well, you didn't fix me. You told me 94% cure, and I'm still, having a few drops. So you will usually are not completely dry. You likely will have a few drops. The same with the sling. Most of the literature on slings will talk about cure as a 1 small pad a day. How do you differentiate between the two? How would you choose a sling versus a sphincter? As I mentioned, 94% of patients would want to have a sling if they were given both options. The sling is actually a really good option for someone who has mild incontinence, someone who's not had radiation therapy. And if you wear 1 to 2, 3 pads, maybe, and it depends on the size of the pads. It depends on how damp the pads are when you change them. Some people change them when they have a few drops. Some people change them when they're completely full. And so your urologist needs to ask you those questions before they can recommend the exact right procedure. But if you're wearing more than 4 pads, or you wear 1 large pull-up and it's very damp or very wet when you change it, then you probably need to have a sphincter. The other question that I find very important is, do you leak at night? And if you do have leakage at night, or if you cannot stop your urination, then you probably need a sphincter, because again, it's for maybe more severe patients. But these procedures are actually, again, been around forever. Most patients would recommend them. There are obviously reasons why you would choose one or the other. One of the important things to talk about with regards to a sphincter is this is like an annuity to a urologist. It's an insurance product for me, because I know you'll be coming back at another time. The lifespan of the procedure is about 8 to 15 years. And so most of the time you'll be coming back for another procedure, because over time the device won't work as well, or you could have some complications associated with it, depending on your history. And then again, your urologist will kind of explain those to you. Insurance covers most of this. I also think it's really important when I'm having the conversation with a patient, and I know we're not talking about erectile function today, but that's obviously a big component of this. Most men, if they're having severe incontinence, won't actually have a conversation with their physician about erections until their incontinence is treated. And I always try to bring that up at the same time, because I want to make sure that I'm opening the door so that the patient it can have that conversation. The other question you get quite frequently is, can I do these procedures? Say I have severe erectile dysfunction and incontinence. Can I do them at the same time? You can, but it's probably not recommended, because success rates are probably lower with regards to the sphincter. So it's recommended you do one and then do the other. Obviously, patients, as I mentioned earlier, are really happy with this device. No one knows it's there, and it can completely change quality of life. I did a advanced sling on a patient about 16 years ago, and I got a phone call. He's now 86 or 87 years old, and I got a text message probably about 4 months ago. Doctor, there's a big problem. I had 3 drops of urine, which I thought was hilarious. So I texted him back. We talked briefly on the phone. He's like, you need to come and operate on me immediately. I'm like, whoa. So I go back to your physiotherapy. I reached back out to him about a month ago. He's now 4 months after that. And he's like, never leaked again. Now that's a success story that I can't tell often, because usually people will have a little bit of leakage. But again, it is a success story that I'm very happy about. So benefits of treatment, obviously, we want to achieve continence, but I think a better statement is we want to improve your continence, decrease your incontinence. no surgeon should tell you they're going to make you 100% better with any of these procedures. Actually, no surgeon should ever tell you that we have a 100% success rate. So understand that we can help you significantly. It gets you back to normal as much as you can, and gets you back to enjoying your life and doing things that you weren't doing because of the leakage. And again, no patient can tell, no other person can tell that you've had the procedures done. So when you look at the two devices, so obviously they're not perfect. The male sling has not been around as long as the sphincter. It was created in 2004, 2005. It became available in Australia, I think in 2006. There's a very small risk of not being able to urinate. When I say that, I mean literally less than 0.1%, probably 0.2%. You can get some irritation at the wound site, obviously post-operative pain. Foreign body response is pretty unusual. With the sphincter, it can break. It can erode into the urethra. And I guess I should have mentioned this earlier. Your urologist will tell you this as well. When you need a catheter placed, it needs to be done by a urologist. You cannot just walk into any emergency room or any surgery and have a catheter placed. That needs to be done by a urologist. And there are risks of infection. And again, the device will slowly stop working over time. And then once the incontinence is back, then you'll usually proceed to have it explanted and another one reimplanted. So I think this is kind of going over everything we've mentioned already. I'm happy to answer any questions and appreciate the opportunity to spend some time with you. I think you're still muted if you were talking.
Sorry. Thank you, Bob. Thanks for waking up at 5 o'clock to join us from your conference in South Africa. We do truly appreciate it. We do have a few questions. I just want to ask you a question, actually. How far are we with developing a device that can be operated, a sphincter, artificial sphincter, that can be operated using your phone or some kind of external device rather than that pump? Which is hard for older people to operate with arthritis and that sort of thing.
Yeah, no, that's a great question. And it's one of those things that we need to be very cognizant about, because I have put sphincters in. I was forced to put a sphincter in a patient who is the partner of one of my mentors, and he had Parkinson's disease and really struggled using it. So you do have to be very cognizant about that. The question, though, is, can we, or how close are we? And I don't think we're as close as we would hope. I know before COVID, American Medical Systems, or Boston Scientific now is the company that had developed it. They were looking at a battery controlled. And the biggest problem they had was they would have to change the battery every 2 or 3 years, where now the procedures changed usually every 8 to 15 years. So I do think we're not where we need to be at this point yet.
And for some people, have troubles with their bladder. They may have a neurogenic bladder. They may need to self-catheterize. You said you can't really catheterize with a sphincter. Is it possible to catheterize with a sling?
It is. It is possible to catheterize with a sling with usually no difficulty. It is possible to catheterize with a sphincter too. And I may be on the minority of urologists, but I do have some patients with neurogenic bladders who have to cath. And it needs to be somebody that we as a physician can trust, because as long as you cycle the device and it's open, a catheter will go in quite easily. So if you could pass a small catheter, drain the bladder, and get the catheter out, you should be fine. But the patient really needs to be skilled, and you need to trust them. If they have any trouble passing a catheter, they need to contact us almost immediately in those situations.
All right, some questions from the audience. You did mention an advanced sling, but you didn't mention the Atoms device. Yeah. Is there a reason?
So, there is a reason, but not a good reason. The Atoms device is not in the United States, so I don't have experience with the Atoms sling. It is a procedure that has good data, and it is a sling that actually has been shown to be better in more severe patients compared to an Advent sling. There's also Virtue, which is a different sling. I have not had any experience with that. And then there's Argus, which I'm not sure, Amanda, is that available in Australia? Do you know?
I'm not sure, actually. I haven't put an Argus one in. Yeah.
It's an adjustable sling, and it has some weird issues. So I would probably not recommend that. I think an Atom sling is actually, as I mentioned, I think it's got good data. It can be used in more severe patients. And so I think it truly is up to what the physician's comfortable with. And then your patient characteristics. If you have more severe incontinence and you really want a sling, then I think an Adams is more reasonable, but a sphincter is also a good option in that group.
Do we have Atom in Australia, Amanda?
Yes, we've got Atoms in Australia.
Yes.
Thank you. Kurt, another question. What's the difference between Kegel exercises and pelvic floor muscle exercises?
So if you ask a pelvic floor physiotherapist, they may have a small heart attack when you ask that question. They don't like the word, at least the ones that I work with don't like the word Kegel exercises. In my mind, they're pretty much the same. But they truly think that Kegel exercises are not always the right statement. I do think that from a patient standpoint, you do need to see a physiotherapist. I will examine patients quite frequently and say, tighten up the muscles that you would do to stop your urination or your Kegel exercises. Unfortunately, that's the word we use. And I would say probably 25 to 40% of patients don't squeeze the right muscle. They cross their legs, they clench their buttocks, they take in a deep breath and bear down their abdominal muscles. So I truly think that you should see a physiotherapist to at least learn how to do the exercises.
Thanks. Here's a question. I mean, I don't think we asked you to go into the specific surgical approaches, but someone has mentioned patients who've had prior radiation who may need an artificial urinary sphincter. Is transcorporeal placement an option?
So I'm going to be interested to hear what Amanda thinks on this as well. So the transcorporeal sphincter is an option. I think personally, so going back 10 years ago, 15 years ago, when it was first described, it was described a little bit before that, I was a big fan of it. And I would use it initially in some patients because I thought it would give me more tissue. It gives you more tissue around the urethra. The disadvantage of it is you lose space. There's only a certain amount of space where you can go transcorporally. And so I think I know what I do now is I will do a normal sphincter. Once that doesn't work as well, I may move it to a different spot. And then I would use a transcorporal as my last option as a salvage option. The other thing is if the patient's sexually active, that can or may affect their erectile function. So again, it's something that you want to use at the end. We were all enamored with transcorporal sphincters when they first came out, but unfortunately, there's some data showing that the revision rates are probably higher than a normal sphincter, but that's likely because these are patients that are getting it after their third or fourth surgery. So it's a good option, but probably shouldn't be the first option.
For those of you that didn't know what we were talking about, corpora cavernosum are the chambers within inside the penis, and it's just a different surgical approach to applying the sphincter around the urethra. The last question for you is a patient that's got a 10 to 80 mils of leaking per day, had a nurse-sparing prostatectomy 5 years ago. Are they a candidate for a sling or an artificial sphincter based on that information you have there?
80 mils seems like a lot. I'm trying to think of how many grams that would be. I don't know if I know the answer because it's interesting. We always look at grams when we describe the amount of leakage.
Pad weight.
Yeah, so we don't use pad weight.
Isn't it, Amanda? I think it's 1 for 1.
Yes, yeah. I'd say it's 80 mils, meaning 80 grams of urinary leakage.
Okay, so 80 grams is probably not terrible. So I think you would be a candidate for either. If you've had radiation, then probably should not have a sling because the results in slings are worse in radiated patients. But I think if you have not had radiation, I think a sling would be a perfect option for you.
That's great. And those are all the questions for now. Once again, everyone, just a reminder to keep the questions coming in the Q&A section at the bottom, or the chat section. We're now going to go back to Dr. Amanda Chung, who's going to tell us a little bit about this concept of the overactive bladder, and how that relates to incontinence and urinary troubles. So Amanda, you can
thank you so much. And I'll share screen. And yeah, thanks for whoever asked the question about the transcorporal cuff. That's a very interesting one. If I can add also, the other scenario where I have used it is, for example, in people who have had problems with radiation cystitis, where they've had, hematuria, and even had situations where they couldn't pass urine because of a blood clot blocking the urethra. And in that scenario, they've had treatments for their, the blood in the urine, it's all calmed down for a while. They might have even had hyperbaric oxygen treatment to help prevent it from coming back. And if they haven't had any hematuria for a while, maybe 3 months or longer, I would be happy to put in an artificial urinary sphincter. But there's always that small chance that that clot retention might come back in the future. And like Professor McCammon, described, it can be a bit tricky putting in a catheter if there's a cuff there, especially the bigger types of catheter that we use, with the 3-way irrigation that can wash out a bladder with the continuous irrigation. So if there could be a risk of that, that could be another scenario where I have favored a transcorporal cuff for someone, just in case they go into that trouble, or if they're needing, regular cystoscopies for concurrent bladder cancer, for example, and I'm wanting to reduce the risk of cuff erosion. So I'll move to talking about the advanced treatments for the overactive bladder incontinence. So we're just changing it up a little bit, starting at...
While you're doing that, Amanda, someone said, Prof, in Australia, we're quite forward, that their physio uses the term lift your nuts to your guts for pelvic floor exercises to ensure you target the right muscles.
I love that.
Nuts Nuts.
Love it. I might borrow that one. So like we talked about, up to 40% of people or so who have had prostate cancer treatments have got some urinary incontinence. We talked about stress urinary incontinence with that intrinsic sphincter deficiency, and that's a bit more common after surgery compared to after radiotherapy. But after radiotherapy, it can be more common to have overactive bladder compared to patients who've had surgery to treat their prostate cancer. And interestingly, overactive bladder can occur even years after radiotherapy. So there are a number of patients I've seen who might be 7, 8, 10, even 15 years down the track for radiotherapy, and they've been okay, and they've had this slow creep of the development of overactive bladder. And the other term that we give that is radiation cystitis. And why is that? Well, the pathophysiology is such that the radiotherapy does change the tissues, and it can be a change that sort of continues to take effect over time. For the, technically, we're talking about things like some fibrosis to the tissues, so the bladder can become a bit more stiff, more spasmodic, or there can be this condition called endarteritis obliterans, where it's more of a vascular condition affecting the capillaries that are in the bladder tissue, and that's where it can sort of stiffen up or become more overactive with time. And overactive bladder can coexist with the stress urinary incontinence. The kinds of symptoms, so lower urinary tract symptoms that we associate with overactive bladder is frequency, urgency, nocturia, and incontinence. And so we often say overactive bladder is not fun, nor is it funny. So meaning FUN being frequency, urgency, nocturia, and the funny being with the addition of the incontinence. Not everyone with overactive bladder has exactly the same symptoms as the next person with overactive bladder. So this is like a Venn diagram which shows the overlay of different symptoms. So the U is the urgency. So not everyone with urgency necessarily has UUI, which is urgency urinary incontinence. Not everyone with urgency has the N, which is the nocturia, but there is an overlap, and so forth. When I meet someone who describes urinary frequency, urgency, nocturia, incontinence, which sounds like urgency incontinence, then after hearing their story, it's very important for me to exclude other causes of similar symptoms. And I might do that with some tests, including a urine test, an ultrasound, and consider doing urine cytology, just to make sure that there's no sort of bladder cancer too. Does anyone know what this is a picture of? This is E. coli bacterium. So UTIs, urinary tract infections, can also cause urinary overactive bladder type symptoms. So we need to rule that out. And this is a cystoscopic picture of a urothelial carcinoma, so a bladder tumor, bladder cancer, which can also cause, frequency, urgency, nocturia type overactive bladder symptoms. So it's important that we rule that out first. But once we've ruled all that out, if we're happy that it's a relatively straightforward overactive bladder syndrome, there is an algorithm which we can follow to navigate the patient journey. So the principle is to go from less invasive to more involved if need be. And like you had said before, Dr. Spencer, starting with lifestyle modifications such as time voiding. So for example, if someone if they were to leave it 4 or 5 hours and then they get that sudden urge to urinate that they can't hold back and can't make it to the toilet in time, and that's when they would spill, well, it might be practical to then tell your bladder to go to the toilet every 3 hours to preempt that really urgent, accident that occurs. That's one way to manage around it. In terms of dietary modifications, we're talking about how to reduce bladder irritants in the diet. So reducing caffeine, tea, coffee, chocolate, fizzy drinks, including sparkling water, spicy foods, and then quite acidic foods. So tomatoes, mandarin, citrus, oranges, grapefruit can be quite triggering for some people. Fluid management refers more to, for example, if the nocturia, having to wake up in the night, is what is the most tiresome about the symptoms that someone's experiencing, then maybe not having anything to drink in the last 3 or 4 hours before bed. And also making sure that, with dinner or after dinner, not having diuretic type fluids like tea, coffee, alcohol, or soups with dinner, so that the body has time to, get rid of whatever urine it wants to get rid of during the day rather than disturbing you at night. Bladder retraining and pelvic floor physio. A physio can help with not only the pelvic floor exercises, but also bladder calming techniques, which can be really useful. Then in terms of the next step, if we've tried that for, say, a few weeks, say a good month to 2 months, and it's not really improved things, we can move on to considering overactive bladder medications. There are 2 main classes of medication that can help with overactive bladder. So there's the anticholinergic class, of which there are several that exist in Australia, and there are even more that exist and are available in the US. But generally speaking, it's oxybutynin, which can be either a tablet or a patch that can be worn on the skin and changed twice per week, or solifenacin, also known as Vesicare, which is a tablet. There's also the beta-3 agonist class of medications. And in Australia, there's only one type of medication within that class called mirabegron, and its trade name is Betmega, and it's a tablet once a day. In terms of side effects, all medications can potentially have side effects. Generally speaking, the side effects, if experienced during using an anticholinergic, would be things such as dry eyes, dry mouth, constipation. There are some people that feel a bit like they've got cognitive side effects or less clear in the mind with it. So we are quite careful using that, especially if someone has a tendency toward that already, or another condition that might cause some cognitive impairment like Parkinson's disease, or are at very advanced age groups. Beta-3 agonist tablets don't usually cause side effects, but if someone was to get a side effect, the things to watch out for would be hypertension. So generally, I have my patients see their GP about 2 weeks after starting one, just to make sure that's okay. If they're already on antihypertensive medication, that's still okay usually. If the blood pressure is just a little bit higher, then maybe the GP might want to, but the medication is working well, the GP might want to just sort of tailor the other antihypertensive medications just to make that all fit okay. Alternatively, if the blood pressure goes sky high, then we might just need to stop that medication and look for alternatives. Other side effects could be headaches or heart palpitations, and if people get that, then I just let them know to stop the medication, and we'll come back and reevaluate and look at other alternatives. So in terms of the next step, if those things haven't worked satisfactorily enough, we would do a urodynamic study, like I talked about before, to see whether someone is suitable for one of the advanced treatment options, or is it that there's a mixture of stress incontinence and overactive bladder, and that's the reason, why we're not really winning with the overactive bladder treatments. So looking at this test, look at the green line here. So as we fill the bladder up to about 128 mils, this person has told us that they felt that first desire to want to urinate. At about 189 mils of filling, they felt quite like they would normally want to urinate. And at 287 mils, they felt like strongly so. And at 338, they couldn't take it anymore and needed to urinate and have a stop filling. So just as a general sort of guide, and it all varies, but generally people would sort of feel like they want to urinate maybe at about 150 or so mils of 200 mils of filling. They would normally want to go to the toilet maybe at about 350 mils. So in comparison, this is quite early. And usually people could hold maybe about 400, 500 before they really strongly felt like they wanted to urinate. So you can see here in comparison, this patient has sensory overactive bladder. So their bladder is hypersensitive. It's telling them that it wants to urinate, wants them to empty before, the majority of people would. So they said it was hard for them to sit through a meeting at work. They felt embarrassed that they had to excuse themselves to go to the toilet. We can also see here on the green line, see how these lines start going up and down after about sort of 180 mils of filling. This is detrusor overactivity, which basically means that the bladder is spasming. So even though they're trying to clench their sphincter real tight, their bladder is really spasming and really making it uncomfortable for them. And if it spasms high enough and they can't clench hard enough with their pelvic floor, then that's when they spill urine, they have urinary leakage. So this is detrusor overactivity incontinence or overactive bladder incontinence, a couple of names for the same thing. There are 3 advanced therapies in Australia for overactive bladder incontinence. So these are pictured here. One is a pacemaker for the bladder called a sacral neuromodulator. And for whoever it was that was asking about a mobile phone that could help control it, interestingly, this one does come with a little Samsung smartphone looking device to help program that pacemaker. There are Botox injections that exist, and there is PTNS, percutaneous tibial nerve stimulation, that exists as well. And I'll go into them a little bit more. In terms of PTNS, that's an office procedure, so it can be just done in the rooms, does not require an anaesthetic, whereas Botox and sacral neuromodulation, in Australia anyway, are generally done in the operating theatre. Although can be done in some day surgeries, or for some people, they might choose to do Botox under a local anaesthetic in the rooms. In terms of the Botox injections, basically it's done through a cystoscope, camera into the bladder, and these little needles made for purpose are used to inject the Botox medicine into the bladder muscle, just to help calm that bladder muscle and help the bladder stop spasming, stop pushing the urine out accidentally, and helping it to hold better. So before this procedure can be done under a local anaesthetic if someone wants, or a sedation or a general anaesthetic. It takes less than 15 minutes to do, and it's a day-stay procedure. So people usually would come into the hospital and go home the same day. Before the procedure, of course, because we're going into the bladder, we want to make sure that they've had a preoperative urine test to make sure there's no urinary tract infection, because there's a small risk of urinary infection if with this sort of procedure. So we usually do that and give some antibiotics as a preventer. In terms of afterwards, people usually go home same day once they've passed urine. It's normal to have a little bit of blood in the urine sometimes. If they keep well hydrated, then usually that just washes out and isn't an issue. And I usually have people follow up in the office in about 2 weeks' time to check how the urinary stream is going and that they're emptying out, and see how well it's worked for them for their symptoms. The reason why we do that at about 2 weeks is because usually the Botox takes about 2 weeks to kick in, and at about 2 weeks is when it tends to kick in the hardest. So from that point of view, if someone was to have a complication, like it relaxed the bladder too much and they can't push the urine out, then usually that would become evident at about the 2 week mark. And that's why I do the flow test and the bladder scan at 2 weeks, to make sure that that hasn't happened. It also means that say come, 5 months later, if someone says to me, oh, it worked really well, but now it's worn off, can we do it again, but can we do a higher dose? I would usually look back at that flow test bladder scan. And if we find that actually it had weakened the bladder a bit too much, I'd be really nervous to, raise the dose. But if there was no issue and they were still clearing well, 2 weeks or so after the procedure, but it just didn't last long enough for them, they want to up the dose, then yes, I wouldn't hesitate to increase the dose for them in the hope that they could get a better durable effect. Otherwise, generally speaking, the effect wears off about every 6 to 9 months. Some people are lucky enough to get a year out of it. But when the effect wears off, then patients will come back to me and ask if they can have a top-up injections. And then in terms of success rate, it's in the high 80s to 90%. Sacral neuromodulation is like a pacemaker for the bladder, but it doesn't sit within the bladder. It actually sits in the lower back. There's a wire that goes down S3 foramen in the sacrum near the S3 nerve root. And then there's a little battery like a pacemaker that gets implanted in the upper buttock area, either the left or the right. Before we go and put in the real thing, we usually put the trial leads first, which are 2 little wires that go down both S3 foramen. That procedure is often in Australia done under a light general anaesthetic or a sedation, and is a day stay procedure. It takes about maybe 20 minutes or half an hour. When people wake up from that, they have 2 little wires just sticking out their lower back with a dressing over the top, so a sticky dressing, and it's connected to a plastic battery, and they wear that with a waistband for a week to 2 weeks to see how it goes in terms of improving their overactive bladder incontinence and overactive bladder symptoms. If it doesn't work well, they don't need to go back to surgery to have it removed. It just pulls out with my nurse in the clinic. If it does work well, then we'll plan the real thing. So for the real thing, it's about a half hour to 40-minute procedure, day surgery also, in the theatre under a short general anaesthetic. And there's 1 wire that goes down S3 foramen. It's tunneled to a 4-centimetre incision in the upper sort of gluteal buttock area and connected to that battery. And so when people wake up from the real thing, there's nothing sticking outside their body. It's all hidden underneath the skin. The battery basically runs in the background, so it sends little electrical impulses down to help modulate the bladder's activity. Although it does come with an iPhone, a smartphone looking device to help program it, you don't need to press that in order to urinate each time. What it does is it helps to modulate the bladder's activity in the background. So you can really set and forget it from that point of view. The battery usually lasts about 5 years. So if it's a high output setting someone's needing on, it might not quite last that long. If it's a low output setting, it can last longer, 7 years, 8 years even. Since the 1st of July last year in Australia anyway, there's been an MRI eligible device. So that was a hesitation that some people had with having this kind of device, but it's become more acceptable because it doesn't mean that you can still have your MRIs if that's what you're needing for other monitoring of other conditions, and it has about a 90% success rate. PTNS, percutaneous tibial nerve stimulation, is the 3rd advanced therapy. This one is a needle into the ankle near the tibial nerve, and the way it works, it's not to inject anything, it's actually to stimulate the nerve. So, and the tibial nerve runs up to S3 nerve roots, S1 through to S4 nerve roots. And it's the S3 one that's the one that's shared the most with the bladder. And that's how it modulates the bladder's activity. So it's connected to this electrical device, and we're stimulating the nerve for half an hour once a week for 12 weeks, just in the office. And you can read a magazine or whatever you like while that's happening. It has a 60 to 80% success rate during that time. And if it works well for you, then your doctor would organize a tapering course over 3 months. So, 2 weeks apart, 2 weeks apart, 3 weeks apart, 3 weeks apart, 4 weeks apart. So spreading out those intervals. And then the maintenance is once a month ongoing. So that's it about the advanced treatments for overactive bladder. In terms of take-home messages, so I think my take-home messages are that not all incontinence is stress urinary incontinence. There are treatments available for overactive bladder. It's important that your doctor rules out other conditions that can cause overactive bladder-like symptoms. And then when it comes to managing overactive bladder itself, there's an algorithm and a care pathway that exists. So many people may improve with simple therapies that might not even be medication or surgery, but just lifestyle changes or dietary modifications. But for people who need it, there are more advanced treatments that exist. Thank you.
Thank you so much, Amanda. You can almost relax now with your talks done. Before we move on to Kurt, though, we just have a few questions to ask you. Just regarding, so some people, people like who have diabetes can get what's called neurogenic bladder. How would that have an impact on their urination?
Great question. Yeah, so diabetes can cause a couple of things. So it can cause almost like a neuropathy to the bladder. It can also cause some vascular changes. So people with diabetes can get an overactive bladder, but they can also get impaired detrusor contractility. So what that means is that the bladder, so just like we talked about, you can have frequency, urgency, getting up in the night to have to urinate, an urgency that can be so strong that the bladder, spasms and it empties out by itself. But on the flip side, it can also cause a problem where the bladder muscle becomes weak such that it doesn't want to squeeze like a pump very hard to push the urine out. And people can get urinary retention or incomplete bladder emptying. And interestingly, someone who comes into the office and says, it's terrible, I have to urinate really often, it can be because of an overactive bladder. Or on the flip side, it can actually sometimes be because someone's not emptying completely. So if they're not emptying the tank completely, it's not long before it fills up again and they feel the need to urinate again. So that's very easy for us to figure out, because it really is doing a bladder scan after someone's tried to urinate or having an ultrasound of their urinary tract to see if that's the case. But yeah, it's interesting and very good question.
I guess and that's why it's important for diabetics to make sure their sugar's always under control. Otherwise, that nerve damage can get worse and worse, right?
Yes.
So we have a few questions. After 4 years, is it too late to come back and then do pelvic floor exercises? So say you did your initial ones after your surgery and then you sort of stopped because the incontinence got better and then things started getting worse again after 4 years. Is it then too late to go back to pelvic floor exercises?
It's never too late. It's never too late. Yeah. So, of course, as we get older and, it's just like any other exercise, if I haven't done pump class for a while, I've not lifted weights for a while or worked out for a while, it's always harder to get back into it. It can be a bit slower. Maybe I might find that, the progress is a bit slower than it might have been for me 5 years ago or 10 years ago, but it's never too late. And it's always good to keep the pelvic floor well conditioned. And even for people who've had a sling surgery or something like that, I often get asked, should I still continue my pelvic floor exercises? And I say, yeah, absolutely. Because, if pelvic floor exercises and that baseline pelvic floor tone is contributing whatever it might be, let's say 50% to your continence, and the sling is doing the other 50%, fantastic. We want whatever contributing factors can, remain to help keep the continence in good pelvic floor.
Yeah, well, that's a great question, isn't it? And a good response. Thank you. Now we speak of caffeine, cutting out caffeine or coffee. Is it the caffeine in the coffee that's the problem, or is it something else? And if so, is decaf then okay?
Yeah, so I think it's the caffeine in the coffee that's the issue. And so decaf is better. Decaf doesn't usually mean completely no caffeine. Often it's just much lower levels. But yeah, it's better than caffeinated coffee.
Now, we spoke about coital incontinence and climacturia, so leakage during lovemaking. What can our participants do to minimize or alleviate that leakage?
So I think all the things that we've talked about so far, actually. So there's two factors toward climacturia, leaking during sex. So it can be part of overactive bladder. So the bladder can be overactive as well. And if there are other overactive bladder features, that usually points to that being more of the underlying cause. So all the treatments for overactive bladder can also help with climacturia. Similarly, climacturia can also be because of intrinsic sphincter deficiency, so the stress urinary incontinence. So additionally, all the treatments that can help with that stress urinary incontinence that Professor McCammon had talked about can also help with climacturia as well. And in terms of trying to navigate it, it's about also still, the general principles of navigating through the less involved, more simple therapies first, and then escalating to more involved things if need be or if wanted.
Flipping back to the pelvic floor muscle exercises, what about just general physical exercise in being beneficial to strengthening the pelvic floor? What about just exercising, going for a swim or cycling or going to the gym? Is that enough? Is it beneficial?
For pelvic floor exercises? I think general condition and health is good. I mean, let's not forget also that one of the risk factors, or one of the things that can contribute to stress urinary incontinence, is if we're carrying too much weight around our abdomen, too much fat or, weight. That's also added weight to the pelvic floor. So it can make it harder for the pelvic floor and the sphincter to handle the weight of the urine in the bladder, if it's got all this on top of it as well. So yes, keeping well conditioned and healthy generally is good. I think that the pelvic floor exercises, because it specifically targets that area, is important as well. So I don't think that we can expect to neglect that, but do other exercises and still hope to have the same success with the pelvic floor. But all these things in combination with each other is, makes for healthy living for sure.
Thanks, Amanda. There's two questions relating to Botox now. The first one is a patient that's had brachytherapy originally and developed bladder neck stenosis or stricture, I imagine, after that procedure, and external beam, brachytherapy and external beam in 2002. They've unfortunately got a permanent indwelling catheter in. But they also have developed overactive bladder with it. They got a flip flow valve for during the day, but there is bypassing of the catheter up to 400 mils a day almost. Would Botox be of benefit for that bypassing of the catheter?
Yeah, potentially. Yeah, it sounds like there's been quite a lot of radiotherapy in that person's treatment. And so I would be quite suspicious that there is overactive bladder there as well. And so one way to know if that's the case is to do a urodynamic study and see whether or not there is bladder spasms causing that incontinence, or whether it's just because the outlet is just open and rigid and therefore just letting it out. But it sounds very much like if there is bypassing and it's not because of the catheter is getting blocked or kinked, that probably there is overactive bladder there. And in that instance, yes, Botox can help with that.
In someone with an artificial urinary sphincter who develops overactive bladder, is Botox beneficial in managing that?
Yes.
Yeah. So would you try medication first, or would you just?
Yes. Yeah. So if someone's got an artificial, just like with anyone really, but including if there's an artificial urinary sphincter already there, yes, we'd try the dietary modifications first, the medications first. And if the medications aren't satisfactory or give adverse side effects that the person doesn't like, then that would be a reason to do one of the 3 advanced overactive bladder treatments, of which Botox is one option and a good option.
That's great. Wow. It's a very complex job you have, isn't it? It's not as simple as just taking that prostate out. There's a lot happening here, isn't there, to understand this sort of. You've got nerves and you've got muscles, and then you've got a sphincter, and then you've got, this whole sort of interplay taking place. You've got to get all the factors right for this urination to happen, or this to stop this leaking.
Absolutely. It's so fascinating, interesting, challenging, all of the above. Yeah.
Yep, which is why functional urology is a whole field on its own. So just take note, everyone, that oncologists, they can treat sort of some cases of incontinence, but when it starts getting more complex, you do need to see a functional urologist who specializes in urination and incontinence. So thanks, Amanda. I'm now going to hand over to Kurt, who's going to tell us a little bit about what we've spoken about before, was sort of those strictures, those blockages that are happening from the scar tissue, either related to the surgery or radiation. So over to you, Professor.
Thank you very much. Just 1 second, I have to minimize. There we go. One thing I would add to what Amanda said about the physiotherapy and starting it in 4 years, I agree 1,000%. I would say, though, that continuing to do your exercises, I think, is important. Just like everything else that we do, as we get older, our muscles are not the same. And I'm starting to see patients who have been completely dry after their prostate surgery and are now 10 years out or 15 years out and are now having incontinence when they're in their early 80s or late 70s. And so I think it's really important to continue to do those exercises, and going back and trying them, I think is great. So for sure doing that, I can't lift as much or run as far as I did back in the day. So it's the same with our pelvic floor. So for the audience, I was apologizing earlier. I was told I didn't have to say anything, but Kalli doesn't know me well enough. I usually say everything. I don't hide too many things. So I actually added some slides that were slightly better from a patient perspective, but it appears on my flight over from America to South Africa, I didn't hit save before I took my nap. And so I'm going to talk about bladder neck contractures or strictures. So some of these slides are going to be more physician oriented, but I did cut out the bloody ones and the ones that no one really wants to see. But what an anastomotic stricture is, it is a scar tissue that would come after prostate cancer treatment, and usually after a prostatectomy when there's scar between the urethra and the bladder. As you know, when the prostate is done, the prostatectomy is done, we take the prostate out, and then there's a hole there, and we sew the bladder down to the urethra, hopefully keeping that sphincter in place. One of the huge advantages of a robotic prostatectomy is that the fact that we don't have a significant number of patients with scar tissue. Radiation does increase the risk of scar tissue after a prostatectomy and or before, but the incidence is significantly lower now because of robotic prostatectomy. The goals in obviously treating these patients are to prevent urinary retention, have patients void normally, maintain their continence, and what should also be here is maintain their erectile function if they're still having erections. What are the symptoms that you may have if you present with this? Well, you'll present with some frequency of urination, probably because your bladder's not emptying. You'll probably be getting up at nighttime and have some urgency to go. You'll have a decrease in your force of stream, and your doctor may or may not be able to place a catheter. You'll have incontinence or may not have incontinence depending on how bad it is. How your physician will work this up is usually it's pretty simple. It's a cystoscopy. It's not usually very difficult to determine. And Amanda showed pictures of us putting a scope and looking inside. So what can we do for you if you have some type of obstruction, either from your prostatectomy or from maybe your radiation treatment? So obviously one is to do nothing. There are some patients who are emptying their bladder okay. Their stream may be a little bit slower, but maybe they're continent, maybe they're doing well. And so first and foremost, see where you are. I met a gentleman about 6 years ago. He had his prostate surgery in 1997, and they tried to put a catheter in at the time of his hernia surgery. They couldn't get it in. Saw one of my partners. My partner said, "Oh, this is bad." He didn't like my partner, so he flew to the West Coast of the United States. So flew 6 hours away to get away from our group, and was told he needed an operation to fix this. Well, he had been voiding fine for about 15 years. He'd been emptying his bladder, no infections. His stream was slow, so we did nothing. And I've followed him now for the last 6 years, and he's done just as he's done for the last 20 after his prostate. So again, sometimes it's doing nothing. There was a question, as Amanda just answered, about Botox in a patient with an indwelling catheter, but some patients will choose to have a catheter left in place. And you know what? That's okay. If that's your choice and you understand the pros and cons, I think that's fine. I have some patients that will do dilation or catheterization and kind of stretch the scar. And actually, I'll show you a device that we have our patients use that actually works very well. You could have endoscopic procedures, and we'll go over all this in a few minutes, but we can show you some pictures. You could have endoscopic surgeries where we make an incision. Stents are currently no longer available in the United States, but there is a newer stent that just got approved, but it's not been approved for this, although people are using it. And then you could have surgery. Finally, there are patients that we take care of where that scar tissue is so bad and the attempted cure of it, my surgical procedure would have such high risks. Sometimes we divert their urine and they have what's called a ileal conduit and have a bag on their side that the urine drains into. Obviously, it's probably not the most favorite thing that somebody would choose, but I can tell you most of my patients that we do that to, their quality of life is significantly better after that. So again, this is called a direct visual internal urethrotomy. And so this is what it would look like. You see the small opening, and we would just take a cold knife and go in and incise it. And if it's the first time and it's a short stricture and not very thick, then this is a reasonable option with about a 50 to almost 90% success rate. And this is a study that we published a number of years ago now. Injecting some type of material may decrease the risk of a recurrence. So we were using steroids, triamcinolone as a steroid. We would make our incisions, and steroids will decrease scarring, inflammation. And so we would inject the triamcinolone. We would rescope the patient in 6 weeks. If the scarring was coming back, we'd actually go back and do it quicker, or again. But as you can see, and I think the reason I left this slide here, it worked for about 80% of the patients, but as you see, almost half of those patients ended up developing incontinence after we were able to open up their scar tissue, and they had to go on and get a procedure to treat that. So that is a risk of all of these treatments, that you may end up getting some type of surgical procedure to repair your incontinence. The Leahy Clinic, there's a young woman, Jill Buckley, who's incredible, and she published using a chemotherapeutic drug where you inject this into the scar. And the reason I left this on here is because people always hear chemo and they hear chemotherapy and they're always afraid. They're like, oh, no, I don't want chemotherapy. This is an extremely small dose, so nowhere near a dose to treat a cancer. But again, it decreases the cells from coming back, and it has been shown in patients who have had pretty severe scar tissue to work, but usually or can require more than one incision for it to work. Again, very similar picture. They make an incision, and then the pharmacist will mix up the mitomycin, and then we will inject it right into the scar when we're done. And as you can see, they had a good success rate, but they also sometimes had to undergo more than one procedure. So some patients end up going 4 times where they had this done, which is okay as long as we got them to be open. But again, not always cured. So I usually tell patients that this works about 70% of the time if they fail the simpler things. This is just another study showing actually long-term it still works. So I mentioned this, something I have patients do. And if you have to catheterize yourself because of a scar, not because your bladder doesn't work well, not because your bladder doesn't empty, but if you have scar tissue in there, this is actually, it's called a Cook urethral dilator. I have no financial ties to Cook, or actually any company at this point. And it is made for a single use only. So I'm supposed to take this in the operating room, pass it in the patient's urethra, blow the balloon up and stretch the scar. That's not what we do. So what we do with our patients is they have scar tissue that we probably shouldn't operate on because of the risk of the procedure, or maybe their health isn't healthy enough to undergo a big operation. We'll go to the operating room. We'll use one of the procedures we just mentioned, where we'll either cut it with a knife or a laser. And then if it's failed once or twice before, the patient will do this daily for the first 6 weeks. I'll then put a scope, look inside, see what things look like. If it looks open, I'll start spreading out the time. Now this catheter costs about $170. And if you look on the packaging, it says one-time use only. But I can tell you, I've had patients use one catheter up to a year or 2. They clean it with soap and water. And again, this is something that is a reasonable option. I'm a surgeon, so I'll tell you, I would much rather operate on a patient. But one of the important things about being a surgeon is knowing who to operate on and when to operate. And then again, there's some people that we shouldn't, and there's some people that can make significantly worse. We have one of our recent trainees is looking at publishing this. And as you can see, we have about 70% of our patients are continuing this, are happy. And so it's not perfect. It's not for everybody. And sometimes it's a challenge to convince a patient to try it. But once you do and they do well, it's actually, they're usually very happy. Now, if they have scar tissue, they're younger, they're healthy, you can do an open surgery. And I will tell you, this is not a small incision sometimes. This would be a big incision because this could be a big surgery. Sometimes you have to make an incision on their abdomen and on their under their scrotum. And at times we've actually had to remove part of the pubic bone to do this. But this is a picture of a patient voiding afterwards, and it was wide open. There are some studies that show 100% success rate. If a physician ever tells you 100% success, I don't believe them. If you look at the study, it was only about 2 or 4 patients. So of course, if they have 100% success, that means they haven't done the operation enough, because nothing's ever actually 100% successful. People are now doing this procedure robotically. And I think that's a reasonable option, depending again on the cause of the scar tissue. If it's a robotic prostatectomy and there's no radiation, I think a robotic repair of this is actually very good. If it's from radiation, people have still done it robotically, but I think the success rates are significantly lower. And as you can see, what you don't know is that the Trauma and Urologic Reconstructive Network of Surgeons is a large group of reconstructive surgeons. And as you see, they only have 12 patients. So this is not something that we are doing a lot of in the United States, or I'm sure in Australia or Europe or anywhere, but there are patients that are having these procedures done robotically. And this is just a picture. I try to take most of the gory, bloody pictures out, but I had to leave one in. So I apologize, because as I said, I did have a few more slides, but so if you have scar tissue and it's from a surgery or radiation, I think attempting some type of endoscopic treatment is reasonable. If your physician is comfortable using mitomycin, I truly believe in it. There are some questions whether it can cause some systemic results, and you just need to make sure you have the right dose. It's not very difficult, but an open reconstruction does work. And then finally, if you are okay with doing the dilation, because if you are opened up and you don't leak, doing the dilation will not cause incontinence. So I think doing the dilation is a really reasonable option and something that at least should be offered to patients at that time. I think this is a quote. Australia has strong ties to the UK, so I can't put up most of Winston Churchill's quotes, but this is probably one that's okay to put up. And I think it's something we should all consider as we live our life every day. So thank you very much for allowing me to join you this morning or afternoon.
Thank you so much, Prof. And yes, I think that's what we get out of doing these support groups, making a life by what we give. And thank you both for such excellent talks, very interesting. And yeah, we're just lucky for you to share your expertise and your experience with us. I think I wanted to also just point out what you said in this last talk about, if you have an issue related to strictures or your urethra, then you need to see someone who knows about reconstruction. That's another type of urologist, a reconstructive urologist. And so functional urologists would deal with all those sort of bladder problems, but if there's a blockage, then it's a reconstructive urologist that's going to do the repair and join everything back together nicely again. The other thing I wanted to pick up on was what you said about the pelvic floor muscle exercises. I teach medical students about the pelvic floor, and I tell them they should start doing pelvic floor exercises now, because you never know what will happen in your life. Are you going to deliver a child, or are you going to have your hysterectomy, or you're going to have your prostate out? You just never know what can happen along the line. So start getting that pelvic floor strengthened now. And to pick up on another point that you said, even though you've had that operation and you think you're clear and the incontinence has gone away, carry on doing it, because with time, as you say, you get older, your muscles fatigue, or they get weaker, or if you lose weight for whatever reason, for another condition, you lose muscle mass, and then you're at risk of developing incontinence again. So we should all be continuously doing our pelvic floor muscle exercises.
Kalli, can I just come in there? First of all, Kurt, Amanda, absolutely brilliant presentations. Thank you so much. As a cancer survivor of 14 years, a couple of your take-home points are just so relevant. We males are not very good at understanding or juggling a number of balls. I can always remember when I was diagnosed with cancer, I truly did not know at that time that I had a pelvic floor. I thought that was just a woman. And then I thought if I go and have pelvic floor exercises, I'm going to end up with childbearing hips at the end of it. But I must say, I've kept those exercises up, and I'm 14 years out now and not had a problem. And Kalli, I think you'll agree with me. I mean, our group has been going now for just on 12 to 13 years. And we've had some 250 men come through our group, our support group, which has been fantastic. But incontinence and erectile function are the two key things that when we get a new member come in who's just been diagnosed and they're trying to pick their treatment pathway, the incontinence one, I would say, followed by the erectile one, is their major concern. And that's what, in some cases, hold men back from having any form of treatment at all, which is sad. And I think I'm sort of very reassured with your presentations today. There is a pathway. You know, if your surgery, in my case, I've been very lucky and 100% on the upside. But there are those that, you know, either it's a bit later, it's got to be a bit more radical in what's been the treatment they've had. And incontinence will be part of the journey, but it doesn't have to be the journey. And am I right in saying that?
Yeah, and Gary, just to supplement what you're saying before I take it back to the speakers is, you know, a lot of patients, I think, are scarred by the initial journey or the initial surgery, you know, that radical surgery that they had took long, the operation took long, the recovery took long, the anxiety around the diagnosis, all the follow-up and checkup. So they're reluctant to go for a second procedure because they think it's going to be like what they've been through already. It's almost like a PTSD, isn't it? But we often spend a lot of time in the support group reassuring the patients that these are small procedures to sort out the incontinence. They're often day procedures or one night stay. The catheter is not going to be in for as long as a week, like it would have been for the prostatectomy. So it's quite important to drive that message home that it's not exactly like your original experience. And in that way, it might ease them into considering going for.
Just one other quick point before we pass over to Amanda and Kurt for our final answers. If you could explain just what a functional urologist is. Here in Australia, and Amanda, you'd probably back me up here, there are urologists where people go and have their surgeries or whatever their treatment may be. They are suffering from incontinence, but there's no referral to a functional urologist. To be quite frank, that term or that title here in Australia has not been bandied around, I would say, until probably a year, 2 years ago. Am I right?
Yeah, I agree with you. I think you're right. Yeah. So in Australia with core urology training, there is a big emphasis on the oncology. And then, you know, the things that happen commonly, like a BPH, benign prostatic, you know, enlargement and kidney stones, there's a lot of that. There is less emphasis, although it is still then meant to be part of the core curriculum regarding what we call functional or reconstructive urology. So that's urinary incontinence, overactive bladder, there's, you know, functional. A lot of people that do functional urology, and not everyone, but some do, also would take an interest in reconstructive urology. If you wanted to give it a broader term, sometimes colloquially, we call it quality of life urology to help separate it from the cancer urology. And I take you know, as Kurt McCammon does, you know, a very passionate interest in the reconstructive and functional urology, the quality of life urology. I, after my core urology training, you know, picked my final year in a unit that also had an emphasis on that in Sydney. And then after that, Professor McCammon was very kind to host me for a year for my fellowship training in the US, so that I could learn from his expertise and his colleagues more advanced surgical techniques and treatments and ways of thinking in functional and reconstructive urology. But yeah, you're right. There is a bit of an overemphasis in Australia in the well, not overemphasis, I should say, but sometimes the functional side is a bit neglected at times, and there are specific urologists that sometimes take a particular interest in that. And I think as time goes on, there's going to be more fellowship trained urologists coming back to Australia, bringing that expertise back, expanding and pushing those boundaries, being at the forefront of that. So Australian, people can also access that same level of care that's available in the US, for example.
Thanks for the clarity, Amanda. Prof, would you like to add to that?
I think what I wanted to add to it is I think the point of you're just diagnosed with prostate cancer, you're kind of in a different mindset. You may hear about the continence or incontinence after surgery, but you may not. And sometimes people just completely miss that. So it's something that some physicians don't mention. I mean, I'm not in Australia, so I don't know what the conversations are, but I can tell you some of my partners who I know have the conversation, the patients tell me they were never told me, or ones who I know don't have the conversation, the patients obviously don't know. I also think that patients need to be their own advocate. And I think that's something important. And that's why you're all doing this now. But you go back and see your oncologic surgeon. You're cured of your cancer, hopefully. But you may not want to disappoint him or her. And you may not even want to bring it up. Or as I was mentioning, I'm at another conference, some of the oncologic surgeons don't think it's a big deal if you wear a pad or two a day. It's not they're not wearing pads. And my conversation to the gentleman who said it last night was, well, why don't you urinate into your underwear and walk around for a few hours and then see how happy you are with it? Because it is a significant quality of life issue. And the patient does need to be their own advocate at times. Hopefully you'll have a very open and good conversation with your urologist. And if they're skilled in taking care of this type of issue, they'll take care of you. But if not, hope to refer you to somebody like Amanda.
Thank you. Do either of you have any final words that you want to say before we round up the talk? Prof, you want to go first? Any final?
No, I think my closing was just that. I think it's really important that we be our own advocates. I wish there was a way for patients to hear this better without the stress of having the cancer diagnosis at the same time. I think that, is such a hard thing to hear. And then you miss some of those other things. I do think it was very important to bring up, don't limit your treatment for the risk of incontinence or the risk of erectile dysfunction, because those can be treated. And I think, no question, most of the time our success rates are actually relatively good.
Never a true word spoken. Yeah. Amanda, do you want to give us a final thought?
Yeah, I'd really like everyone to know that it is more common than you probably realize. And it's great, joining support groups like this, because then you start that conversation and you realize that. And I think that can take away a lot of the embarrassment and stigma and, psychological suffering that does come along with a lot of these, incontinence or erectile dysfunction issues. And I would like everyone to feel empowered, that there are treatments available. They don't necessarily mean surgery if that's not what you want, but have that conversation, advocate for yourself, talk to your doctor about it. There are treatments available, and have that conversation. I also want to pick up on what Gary said, about it being a journey. It definitely is a journey. That's one of the reasons also why some things just need to be addressed in a stepwise sort of way. And that's why I also have that, that sheet spelled out with the pathway, because if at the first consultation, I tell someone, dietary modifications, I don't want them to go away and try that and not get success and not feel they can come back to me or not think I have other tricks up my sleeve. I want them to know there is more. So keep knocking on your doctor's door if you're not getting the results you want. And, you know, there is more, and they can help partner with you to lead you on that journey to better quality of life.
Thank you so much, Amanda. Yeah, your relationship, I think, with your practitioner is very important, and you should feel comfortable and feel like you could be open up and disclose to them and share anything you need to. So that's also very true. So yeah, I think that brings us to the end of our conversation. Thanks to everyone for joining us today and for all the questions that were asked. We will have another webinar coming up in November. We will be talking about the latest treatments available for prostate cancer. And that's with Professor Philip Stricker, also an Australian urological oncologist. So on that note, I'll leave it to Gary to close.
Thanks, Kalli. Yes, the date of our next webinar is the 26th of November. Title is Prostate Cancer 101. So we'll be bringing Philip with new and updates on treatment at that time. Before we do go, I'd just like to extend a big thank you to both Kurt and to Amanda. Just fantastic. Thank you so much. You've really imparted so many pearls of wisdom, really, for people that are in either going through the journey or about to start it. I'd also like to thank our sponsor, Boston Scientific, for their support this year. We've done 4 of our 5. The Prostate Cancer 101 is going to be our last one for this year. They've been fantastic in supporting us this year. And also the Prostate Cancer Foundation of Australia. If you need any advice, you can go, I think you can see on our background there, the website for the Prostate Cancer Foundation. Again, great information there, and they're there to help and support both from their website and also through their telephone services as well. Over to you, Kalli, to wrap up.
Well, I think that's it. So we'll just end the call, everyone. Thanks again, and have a lovely day further.
Take care.
Thank you so much.
Bye.